Good afternoon, everyone. Thanks for joining us for what is crazily our October Community Roundtable. This is one of the roundtables where we sort of take it back from the PMO, and we're going to do a big review of all of the use cases and where we've progressed this year and what's coming up. If you can flip to the next slide, Crystal. Just a reminder that here in Da Vinci, we live under HL7's antitrust umbrella, and so we always try and be mindful of not doing anything that could be construed as anti-competitive. You can flip to the next slide. I'm really excited about the group that we have together today, and we've divvied up a number of the use cases across both our leads on the use case, and we've got some member volunteers and Crystal, our project manager. So presenting today, we have Crystal Kallem, who's the project manager for Da Vinci on the part of the POCP team and the PMO, Teresa Yunkin, who actually helps lead our VBPR use case, Mark Scrimshire, who leads the PDEX use case and helps sort of do the umbrella of the other PDEX IGs that fall under that, and Mike Gould, one of our Da Vinci champions, one of our original Da Vinci champions, and he helps lead our architecture group here at Da Vinci and really sort of lends in and is actively implementing a number of the use cases in his role at ZeOmega. We're going to do a quick update at the beginning of the call just on sort of logistics and where Da Vinci is going to be, and then I'm going to hand it off to Crystal, who's going to do a little review of sort of current state, and then we're going to dive right into the details of all of the happenings around each of the individual use cases. You can flip to the next slide, Crystal. Just a reminder from a housekeeping perspective. Oh, I'm sorry, go back one more. Just a housekeeping perspective, just remind if you've got any questions, please ask them via the question link. We'll pick them up as we can in talk track, and we will try and preserve some time depending on how quick we get through material today for Q&A at the end. Anything we don't answer, we'll typically pick up in another thread from a project perspective. If you're having any audio issues or quality issues, we have found some issues with GoToWebinar over the last couple of meetings. I would suggest you drop or try and change or remove your audio settings and re-log in. We appreciate that everyone's here. We do record everything, so it will be available tomorrow if you do have any issues or if you want to share this content with colleagues. Keep going. So we will have one more community roundtable, and we are anticipating that we're going to do it the fourth Wednesday. We're still debating whether or not we combine it with one of our other meetings. So we're slated for November 22nd, and there we'll talk about sort of our year-end wrap-up and what we've got planned and on the docket for 2024. And as usual, you can find everything via our Confluence calendar, and that is also where we post the recording. Keep going. We have a number of upcoming events, and we actively track those. If you don't get the Da Vinci newsletter, I would suggest that you sign up for the listserv, which can be found on our member welcome page on Confluence. So we will have members attending and presenting at the WEDI National Conference next month. In addition, I want to raise folks' awareness to the fact that CMS is actually doing another day-long webinar on November 15th. Once you register, there is a little bit of a draft agenda. We're getting a feel from the CMS team about what's going to be included in that. And if you weren't aware of it, ONC is actually going back to having their annual meeting in person in DC for 3 days in December, or 2 days in December. So we're really excited about that and encourage folks to let us know if you're going, because we're trying to debate whether or not we try and do any sort of a Da Vinci add-on to that event. And if you haven't already started planning for it, we find, especially with the January Connect-a-thons, if you're planning to come and test, go ahead and get involved and let us know that you're coming and get registered, because Connect-a-thon comes really fast immediately after the holiday season. And so we find the teams that are best prepared are the ones that really are getting their game plan in place in November and early December before everybody starts to slip away. You can flip to the next slide. I just always want to do a reminder, especially this time of year, we're actually actively recruiting 2024 members from a Da Vinci perspective. For folks who haven't been following along from home, we actually lowered member costs over this past year and have been broadening the base of people supporting as more and more of our work gets intertwined with industry. So if you haven't already learned about what it means to be a member of Da Vinci beyond just participating in the community, we'd be more than happy to talk to you about it. And there's some resources and links there also can be found on Confluence just to learn about what it takes to get involved and what does it really mean from a participation perspective to sort of step up and actually be a sponsor of the project or be sponsored to be into the project. You can go to the next slide. And this is just a reminder of who our current 2023 members are. I'm actually really excited to share one of our priorities for this year was to include more and more of the Q-ins from a project perspective. And we had eHealth Exchange join. And we've got Health Gorilla almost over the line. We're just waiting for the signed SOU back out of their systems. But we're super excited to actually start to look at what does it really mean for people to invoke these Da Vinci Implementation Guides and APIs via networks. You can go to the next slide. And just a reminder, we set up, and we'll have the 2024 version next month. We set up basically expected pace of moving between the ballot and publish process across the breadth of IGs that we're working on. And you're going to hear about where each IG is in reality. But I'm really excited that the community itself, there's so much that's unpredictable at how we publish and go through the publishing process because there's so much, in consensus building. But I'm excited that we've really, tracked, not exactly to on date, but we'll bring the majority of the guides either to a published cycle this year or into the next ballot cycle or initial ballot cycle. And we continue to have really great participation, both in between and at Connectathons from a testing perspective. And Crystal, if you want to flip to the next slide, I think that to me, one of the things that's really important here is about sort of the maturity of the guides and how we look at them, right? So about 2 years ago, we decided that just talking about where guides were from an SDU perspective didn't really give you the full picture. And so what we really look at, and you'll see in the layout of today's slide, is this idea of that there's a regulatory element, right? People pick up and use a guide that's less mature because it's being referenced in regulation or as a resource for regulation. We also are seeing there's reality around sort of how mature a guide is. Not that it's progressed all the way through an SDU, but maybe has light implementations, but things that have actually gone into production. So we give weight. And so we basically came up with a rubric, sort of 3 ways of how to delineate sort of the depth and the density of maturity of the guide beyond just that sort of STU level. And I think that is really important. And we're going to flip over, and Crystal's going to pick up and just start talking about what it is that we progressed this year. Thanks. And you guys can actually all go off camera except for Crystal.
Great, thanks, Jocelyn. So you probably, many of you have probably seen this slide before. We do try to maintain it over time, but this slide is very rich in information, and it applies that readiness scale to each of our Da Vinci implementation guides to provide an overall status at a glance. So as Jocelyn mentioned, the colors represent the overall maturity of each guide. And then we have these dials on the screen that actually represent progress toward a phase in the project, such as its progress toward a current ballot cycle and or publishing cycle. There's also asterisks and diamonds on this diagram next to certain implementation guides. And so those symbols actually represent support or alignment with existing or expected federal regulations. So this slide is meant to serve as an organizing construct to help the community and our members clearly see the status and progress of the program and understand where each guide stands as it progresses through the standards development process and through adoption. Much of our session today is focused on giving you a status update on each of the implementation guides, but there are a few use cases that we won't be reviewing in detail today, so I wanted to mention them briefly before we move on to subsequent slides. The first is the patient cost transparency use case. We did cover this use case in depth during last month's Community Roundtable. That session included an overview of the No Surprises Act law and the benefits of testing and implementing the PCT implementation guide. So take some time to review the recording from last month's session to learn more about PCT. I guarantee it's very valuable information there. So we won't be covering that today. Moving over to the foundational assets of this diagram for just a moment, the implementation guides in this category are cross-cutting and are often referred to as our tools in our Da Vinci toolbox that can support a variety of our other use cases. So one of our newest use cases in this category is the postable remittance use case. This was launched as a discovery project in February of this year. And it's exploring the excessive time and effort spent by payers and provider organizations to obtain remits. So we won't be covering this use case in detail today, but we will share more information in the coming months as this work matures. But we're very excited to see the broad interest and participation in support of this effort, with nearly 30 of our Da Vinci members attending these discovery calls. I'm going to talk briefly about our Health Record Exchange, or HREX implementation guide. This implementation guide was published in March of 2022, and this guide serves as a foundation for all of our Da Vinci implementation guides. It defines the FHIR profiles, operations, and guidance that are relevant to all of our Da Vinci use cases. So implementers who are using our various Da Vinci implementation guides should be aware of and understand HREX. It's been expected that HREX would evolve as additional shared content needs were identified through our development and testing activities of other Da Vinci use cases. So coming in 2024, we do anticipate the need to enhance HREX to incorporate commonalities that have been identified from our other Da Vinci use case guides. We're also exploring the newer versions of US Core, and pending any regulatory changes, we may need to update which version of US Core is referenced in HREX. And we will be enhancing HREX based on implementer feedback. So stay tuned for more activities on HREX in the new year. We will be looking at that further. So moving into member attribution, just wanted to talk a little bit about this implementation guide. It provides trading partners with the ability to establish, validate, and maintain a list of members or shared members. So we recently balloted STU2 of member attribution in January of this year. And the most recent updates primarily support reconciliation of patient lists to add and remove members. And it also included changes to the group resource to support other implementation guides, such as gaps in care, risk adjustment, and PDEX. In addition, the member attribution STU2 now supports alignment with the CMS data at the point of care pilot program, giving providers access to Medicare claims data for their Medicare patients, and the CMS beneficiary claims data API, which serves accountable care organizations participating in the Medicare Shared Savings Program and other eligible CMS alternative payment models. So as part of the most recent update to this guide, we also generalized the attribution list profile so that it could support multiple use cases that require patient lists. So this is a scenario where, looking ahead, we expect that this profile will eventually be migrated into the HREX implementation guide as a foundational component for use across all implementation guides. There are two example member attribution list exchange scenarios that are described in the member attribution implementation guide. And in this first scenario, the payer uses historical claims and other information about members to create a member attribution list for the provider. And once that provider receives the list, the provider reconciles the list internally and notifies the payer about any specific changes. So then steps 2 and 3A in this diagram will be repeated as many times as needed. And once that list is finalized, the payer and provider agree to exchange that list periodically. This is currently considered the most common workflow, where the payer informs the provider of the list and makes that list available to the provider in regular intervals. This particular workflow was included in the original STU1 version of the member attribution implementation guide. This next scenario, or scenario number 2, was recently added to STU2. So in this scenario, the provider creates the member attribution list in the payer system. And once the payer receives the list, the payer may reconcile that list internally and notify the provider of any changes. The provider reconciles the list internally and uses the member add or the member remove APIs to add or remove members from the list. And steps 3 and 4 may be repeated as many times as needed until the provider and the payer agree upon that final list. This same list can be used as the starting point for the bulk data access process to extract requested data for all shared members in the list. And it can be made available in ND-JSON format for easier exchange of large volumes of data. So we're really excited about this new and enhanced functionality, and we need people to come help us test these scenarios and provide feedback for ongoing improvements. So we're hoping that folks will come and test at the upcoming Connect-a-thon in January, especially in support of this newly added functionality in STU2. So to get involved or share your experiences or plan for testing at the upcoming January Connect-a-thon, we encourage you to join our member attribution calls that take place every other week on Wednesdays at 3 p.m. Eastern, with the next call taking place next week on November 1st. Jumping now to notifications, which is the last implementation guide in our foundational assets. This implementation guide was published in October of 2020, so it has been available for quite some time. And this guide provides a defined format for sending unsolicited notifications to appropriate actors triggered by a request, with just enough information to know if action is needed. Several of our members have leveraged this utility implementation guide across early adoption FHIR projects, and we've received some feedback from those early adopters and plan to do an STU update after the first of the new year. So that is forthcoming. And this slide simply provides you with a bit more detail in terms of what we anticipate might be included in that STU update for your reference. And again, if you have feedback on the guide, we do welcome additional feedback and are looking for those who have implemented the guide to help us understand if there's further enhancements needed. We're also assessing if and how to align with the Direct Trust Notifications Implementation Guide to support compliance with CMS ADT conditions of participation. The use of V2 or version 2 ADT messages is expected by the Direct Trust Implementation Guide, but the guide itself is not limited to V2. And it does call out the Da Vinci FHIR Notifications Implementation Guide. So as a result, our Da Vinci Notifications team conducted a mapping between the Da Vinci Notifications Implementation Guide and the Direct Trust Implementation Guide to provide guidance on how to represent these same elements in the notifications FHIR profiles. And then also this mapping includes alignment and choices for vocabulary binding. So we're hoping to obtain feedback from the community about the use of the Direct Trust, about your use of the Direct Trust Implementation Guide in production, and whether these types of mappings would be helpful for ADT or any other use case. So we're encouraging folks to join our Da Vinci Notifications community calls. We hold those calls quarterly. And if you have any feedback on that alignment with Direct Trust or on the Da Vinci Notifications Implementation Guide in general, please join our next call on December 6th at 1 p.m. Eastern, and we would love to hear your feedback. So with that, I'm going to now turn it over to Teresa, who's going to cover our quality and risk related implementation guides.
Thanks, Crystal. Thank you for that. And hello, I'm Teresa Yonkin, and we're going to cover the 3 quality and risk IGs, as Crystal said. The first one that we're going to cover is the data exchange for quality measure and gaps in care. Now, this is a standards-based way to exchange the data that you need to close open gaps that have been identified by a payer to meet their quality reporting criteria. So the intent of the framework itself is really to define, the guide is to define and to enable automatic data collection and submission, limiting the need for manual processing and interventions, because we know that this is a very manual process every year. DEQM is the first use case that's been handed back to the community for ownership, and that means that there was enough support and interest in the industry to continue to support the work of the IG outside of the Da Vinci PMO, not to be supported by that anymore. And we've recently published the standard trial for use 4, and that happened this month in October, so that's very, very exciting. Next slide, please. All right. So in STU4, the publication, when it came out earlier this month, the guidance was updated by the community. And so here's just a summary of what was done. The general guidance section gives overall guidance, including preconditions, assumptions, and an overview of the FHIR artifacts that are being used in different reporting scenarios. It's really helpful if you're a new implementer to have this sort of information so you know exactly what your teams need to do so that you can actually have real exchange between a provider and a payer. The data exchange section gives guidance on the interactions between consumers and producers. That means people who are consuming the data, usually a payer, and the producers are usually providers who are creating data, the data that's going to get exchanged. And they're exchanging this data to complete a measure, right? To satisfy a measure. So individual reporting, that section gives guidance on the interactions between reporters and receivers to exchange the individual reports for a measure. So the reporters, again, are the payers, receivers are the our partners, could be federal partners, state partners, and it depends on which way the exchange is going as well. Summary reporting sections. Now that gives a little bit of guidance on the interactions between the reporters and the receivers to exchange the summary reports for a measure. And we know that that's important because we need to understand who, and we need to understand the population that's coming across for those measures. So one thing I would like to point out, and you'll see it pointed out here on the slide, you'll see the red links that are in there, that DEQM is closely aligned with the QI core, the quality measure IGs, and clinical quality language standard. So right now the group is currently working on the next version of the IG, and it's going to be testing at the January Connectathon. So we invite you to come and test. We know that both providers and payers are interested in quality measuring on both sides of the fence, whether it's quality improvement or if it's promoting interoperability, any of the programs that they participate in. So the IG is also looking to ballot in Q2 of 2024. Right now, discussions are focused around bulk data. They're starting to have those discussions, right? So how do you get large amounts of clinical data to do gap closure and to minimize provider abrasion? Because that is a real problem. They're also talking about provenance. So how to authenticate the data to meet and to satisfy quality program requirements that are out there. And finally, as always, because this is now a community-based IG, they're looking to the implementers to come and to continually improve the IG as we go along to meet the needs that implementers have. And you can join these meetings. They happen every other Thursday from 2 to 3 p.m. Eastern time. Have the next slide, Crystal. Ah, there it goes. It's a little slow today. Don't know what's happening with the internet. So risk adjustment, one of my favorite things, risk adjustment. And when we talk about risk adjustment, we're talking it in the context of like the CMS Medicare Advantage risk adjustment program. We know that there's HHS risk adjustment programs, but it's this quality risk, not necessarily just the financial risk. Now, this IG enables standard exchange of risk adjustment coding gaps, supporting documentation, and the submission status of chronic conditions between the providers and the payers, so that they have the providers and the payers who have shared populations. As you can see here, the use case is maturing. If you look up in the upper left-hand corner, STU1 was published in June of 2022. STU2 was balloted in May of 2023, and we are still in active ballot reconciliation. The use case is going to be participating in the January Connectathon, and it's looking for testing partners, and they anticipate that the publication of STU2 will be in Q2 of 2024. Can we go to the next slide? Right, so you can see here, this is the Medicare Advantage workflow, and this is in the IG, and you can see across the top part of this, the flow is pretty much CMS allows the payer to offer a Medicare Advantage plan. The payer sends a risk coding gap report to the provider group. The provider group then does what they need to do. They schedule a visit with the patient after the patient comes in, and they examine the patient and do their documentation. the appropriate codes get captured. Now the provider then submits those diagnosis codes back to the payer, and the payer sends those codes to CMS. And it's very interesting that the workflow here, the first set of it that we did from a payer to the provider group. And now we're looking at the bottom half of this green circle here going the opposite direction. So the provider who's going to submit some sort of documentation or codes or maybe just a note that says something back to the payer of, I understand that I have an open gap and I'm not going to address it right now. So right now the use case is working on that, that communication back in that feedback loop. So specifically the use case is looking at the communication, and they're looking at remediation of those risk adjustment coding gaps. So are they going to be able to close it? Can they provide documentation? Or maybe they just need, like I said, to send a note back. So some sort of annotation to the gaps on the report. Now the provider can have somebody working on their behalf, such as a certified risk adjustment coder or a vendor who goes out, and we all know about chart chase. They go out there and they chase charts, they get the evidence that comes back. Well, they can also submit that back to the payer on behalf of the provider. So one of the things that we'd like to do is to make sure that the provider can add some sort of note that says, hey, this is the information that came from my vendor, or that came from the vendor who's doing the collection of this back to the payer. And it shows that there was some action taken for a specific coding gap that they can communicate back to the payer. And STU2 also includes draft content that introduces digital condition categories, and that describes how to specify a digital condition category using clinical quality language. So CQL, and I talked about that before in the last use case for DEQM. Now, they have an example which is going to allow for a more automated process of generating those risk adjustment coding gap reports by evaluating those digital condition codes against the clinical data that they already have. So looking for efficiencies, we also would like to have implementers or anybody who's thinking about implementing for risk adjustment to attend the meetings, and those are on Thursdays from 3 to 4 p.m. Next slide. Now, finally, to complete our quality trifecta, we've got the value-based performance reporting IG. Now, this is a newer IG. It started in February of 2022. If you look in the upper left-hand corner, you can see that our little arrow is still down here at STU1. We have actually balloted, and we're very excited about that. And we anticipate, we're in active ballot reconciliation right now, and we anticipate publication of STU1 sometime in the first quarter of 2024. This particular IG, it defines how to standardize the value-based performance reporting format and the exchange methods between the payers and the provider. So STU1 supports the payer sending a payer-generated value-based performance report in a standardized format to the provider on an interim basis, so that providers can actually see how they're doing throughout the reporting period, and they don't have to wait for financial reconciliation at the end of the contract period to see whether they've hit their targets or not hit their targets. Can I have the next slide, please? So again, if you look at the slide here, you can see that there are a lot of current challenges with VBPR reporting. It's very manual. All of these payers have different, providers have different payers, and the payers get information from providers in different formats. It can be in Excel, text-based PDFs, it could be PowerPoint slides. It's a very manual process for both sides to consume all this data and get it into their performance reporting applications. Next slide, please. So the use case actually went out and we collected a bunch of different performance reports, quality reports, financial reports, like benchmarking, utilization, and we looked at all of that and decided that we would try to build a good foundation for any sort of value-based performance report, all the different categories that we could to build it out for that to be foundational. Next one. Again, phase one, we're sending the payer-generated report over to the provider in some sort of standardized format. That's what we're working on now, so the top half. The bottom half, we're going to look at just like we did. We stair-stepped it with risk adjustment. It's going to be the same sort of process where then we can say, the provider can say, hey, you know, here's information that I have that says I am performing better than what you have, because we all know that we've got claims lags and in different circumstances where reporting doesn't always happen right away, and evidence doesn't get transmitted right away. So we can go on to the next one. I wanted to really be clear. The value-based performance reporting IG has links to a whole lot of other IGs. So if you look at this, right, this journey here, you have to have an established VBC relationship, some sort of agreement that's there. That's an out-of-band process. We don't account for that in the IG, but we do account for collecting the contract information. So we need to have that. So you've got to have a relationship. The onboarding and the establishing of that infrastructure happens, and that can be done with the value-based performance reporting use case as well as the member attribution use case. The performance on the contracts, as you'll see here, this is great. We are reporting on a population level, not at an individual level. So we are collecting information from member attribution, payer data exchange, and the clinical data exchange. We can get data from DEQM and gaps in care and risk adjustment to provide us the information that we need to populate these value-based performance reports, which is amazing. Again, it's the same for measurement and reporting, right? We can get information from all these different other IGs. We feel the VBPR IG is kind of the culmination of many different IGs. So it's very exciting to us. Next one. All right, so our FHIR resource profiles, this is going to be good. So right now, the value-based performance measure report is a one-to-one measure, and it's that's your contract reporting. So you'll see that across the top. So it's something for every value-based performance measure report, you got to have a measure in there somewhere, right? There's got to be some sort of financial or some sort of benchmark. You're performing to something. At the very bottom, we reuse the DEQM evaluated resource, and we can have 0 to many of those. If you have a contract that is only based in maybe activity-based, not necessarily quality, you can still use our the VBPR resource profile. So as we go along here, you can see that we're also collecting value-based performance quality measure report. That will be your quality measure. So it can be anything from DEQM, it might be a risk adjustment that gets included in here. So it's very important that we're, again, reusing profiles that you've already built for other IGs. Next slide, please. Lastly, just really want to talk about familiarity, flexibility, and scalability. When we built out the IG, we've allowed for these extensions and these code systems and value sets because we know that every VBPR contract is between one payer, one provider. They don't mirror each other. They're not the same. So this is where you can start to really work with your trading partners and do it in a standardized way to get that familiarity, flexibility, and scalability. As you can see, our program models, we used some of the HCP land framework categories. We talk about payment streams, shared savings, care coordination fees, quality incentives. If you're gated on quality, we talk, our contracts collect the line of business, right? Medicare, Medicaid, commercial, paid through dates, performance metrics. How are you performing to capitation? Or we're looking at member months and different thresholds, because thresholds is one of those more complicated pieces of reporting that has to do with performance, right? Like I've hit my HEDIS 50th percentile. So just wanted to give you guys a flavor of what we're working on. We would love to have you at our meetings. They are on Mondays from 2 to 3 p.m. Eastern time. We are looking for more partners to test. We will be at the January Connectathon as well. And looking for testing partners. We have very active Providence, and if you want to get connected with them, please reach out to myself or Yen Harris about connecting with them. Thank you for your time. I'm going to pass this on over to Mark Scrimshire, and he can start the PDEX IG.
Hi there. Thanks, Teresa. Great review. So let me talk to you about payer data exchange. So PDEX is part of the Clinical Data Exchange set of guides. It's been around for a while. It was referenced by the original CMS interoperability rule. And basically the way I consider it is effectively a wraparound of US core, but then adds a few elements that are really more payer specific. So it adds a couple of additional profiles, and some of those profiles we're now seeing being incorporated into later versions of US core. So it's an important IG, and it has some companion IGs with PlanNet for provider directory and formulary, which we will cover also in this session. So what's been going on with PDEX? We actually published an STU2 version back in May of 2022, so last year, and we've been going through ballot reconciliation, and a lot of additional feedback post-ballot has come in, which we've been incorporating. With the release of the advancing interoperability and prior authorization rule at the end of last year, it became obvious that there was going to need to be a prior authorization profile that was suitable for consumption by consumers through consumer apps. And so one of the big additions in the STU2 version of PDEX has been the addition of a prior authorization profile that is based upon the EOB resource. And I'm sure in the next session, Michael Gould will talk about the burden reduction IGs. We leveraged in a big way the prior authorization support implementation guide and the use of its extensions to express what is happening with a prior authorization. So that's incorporated into the latest version of that prior authorization profile. In the current, the STU2 version, there is also a payer-to-payer exchange, and there's been a lot of time spent around refining that payer-to-payer exchange for a single member. Now, again, the prior authorization rule that everybody is expecting is actually talking about this being a bulk exchange. And so, as you can see in the looking ahead, we need to actually accommodate that requirement in PDEX. But we have been working through the whole process of member match and being able to then exchange data between two payers. We also will look at some of the related IGs. So if you look at formulary, there's been some significant changes in the STU2 version. A lot of structural changes came about as a result of feedback from the industry as they went through implementing, and formulary, PDEX and PlanNet have been implemented literally hundreds of times across the industry. The PDEX directory of PlanNet, the provider directory, there was a 1.1 version published. It included support for the active status of providers in the directory, and that was directly related to the No Surprises Act. Looking ahead, where we're at with PDEX is it is referenced by the CMS prior authorization rule, CMS 0057. And in that rule, of particular relevance to PDEX is that this requirement for a payer to provider, a provider access API. Now, this will be a bulk API that will release the clinical data, either basically the same data that is made available through the patient access API for members, will be available to the provider, and it will be a bulk exchange. So it basically enables a provider to come knocking on the door of a payer if they're in network, do basically say, tell me what you know about my patients, and be able to choose the data that they want to pull down and incorporate. We did some very early testing with the attribution IG, so that was covered earlier by Crystal. And we are, as we go through looking at the bulk requirements for the provider access API, of how much of the attribution implementation guide we can actually leverage. We're actually working through in calls, weekly calls, currently on what that API looks like. And so we are really calling out to both providers and payers to give us feedback on how this API should actually work. Will providers, for example, want to be able to connect and, for example, pull the information about the patients that they are seeing that week? Or are they just going to do a regular pull of all of the data that are patients that are attributed to them? So there's a lot of input we're looking for to make this an actual usable API that providers will want to leverage. The other side of that rule is also to require that payer-to-payer API, where we've designed a single member match function and being able to retrieve data about a member, to be able to actually support a payer submitting a whole list of members that are transitioning between plans. And that will also support the situation where a member has dual coverage with two plans. So you have overlapping coverage, and the plans will be able to exchange data so they can better manage the program for the member, knowing what is being provided by the other payer. So another part of this that we have to address is really how will payers know that they are talking to other payers, and obviously how will providers get registered to a payer's API. When you look at the provider directory, you typically see, for example, a provider is talking to or connected with maybe 20 payers. So how can we make it so that these connections to these secure APIs can actually be registered at scale? That is something that we've really got to work out, and whether solutions like dynamic client registration for use internally within a payer is something that's a solution, or is the fast UDAP protocols going to be something that could be used. We've really got to look at these options and see what is going to work for the industry. Again, we will be testing. We are putting together a plan to test at the January Connectathon, and look forward to both providers and payers and vendor organizations getting involved as we work out the wrinkles in these APIs. Let's go forward to the next slide. So it is a bit complicated when you look at, particularly when we start to look at the prior authorization rule and the requirement for the API for both provider access and payer-to-payer. There's a requirement to make available the clinical data. That is already covered by PDEX today. We create that data set, can make that available via the patient access API. But those APIs also require that the prior authorization and actually the status updates of those prior authorizations are made available to both the patient through the patient access API, but also to providers and to payers when you transition from one plan to another and you instruct your payer to go and get your prior information from your previous plan. And within that rule, it also has a statement about, for the payer-to-payer and the provider access API, not the patient access API, for the two bulk APIs, that claims and encounters with the non-financial view of those records be made available through this API. So we are working with the Kallem Alliance and the Kallem Blue Button Implementation Guide, since they've invested a lot of time and energy into defining the claims information in terms of EOBs for patients, which met the requirement of claims and encounters in the original interoperability rule. We're working with them so that there will be non-financial profiles based off of the EOB available from the Kallem Blue Button, and those can be incorporated into the data set that is released by bulk APIs to both other payers in the payer-to-payer exchange and to providers through provider access. So this does actually raise a lot of questions as we approach the next update to PDEX, as to how we incorporate all of these connections in terms of versioning with the prior authorization support IG. With HREX, we actually leverage HREX for things like the member match function in payer-to-payer today. How are we going to tie in with Kallem Blue Button in terms of incorporating this? These are all questions that we will be addressing in the next update of the IG. So lots to cover, really valuable that we get input from the payer community and the provider community about making sure that these APIs are going to meet the needs of the community. Let's go on to the next slide. Let's talk a little bit about formulary. So formulary has gone through a fairly major restructuring. In the original version, the STU1 version, we had a list element that would have all of the medications pointing to the medication knowledge. In the STU2 version, there is basically a basic resource that has created a list item, and that has come about as direct feedback from the pharmacy benefit manager operations and others that have been implementing this in making it easier to manage these formularies, particularly when you have multiple formularies available. The guide still has really two modes of operation. Under the existing interoperability rule, the formulary information should be made available as a part of the patient access API, i.e. it is a secure API that you have access to when you're a member, and it should link you to the formulary that is applicable to your medication plan. When we went through that, the implementation of the interoperability rules, CMS made it clear that yes, formulary needed to be part of the secure patient access API, but it is a payer's option to make it available as an open API, effectively a shopping API, just like provider directory. And if I was to put my implementer hat on, I can tell you a number of plans that have come back to me and said, isn't it just easier if we could implement it as an open API? But unfortunately, it's a requirement of the rule. You have to make it part of the patient access API, but it is your option to make it effectively a shopping API so that prospective members could see the formulary. So there is also within the formulary IG, the STU version, a draft version of a bulk download for formulary, so that you could basically go and come in as a consumer app and pull all of that information rather than having to hit the API individually. And we'd love to see people actually trying to test that that feature in the current implementation guide. So please, if you're interested in that, we'd love to see you at the January Connectathon, and in fact in the run-up to that, so that we can actually plan to actually perform that testing in January. Let's actually go on to the next slide. So what does this look like? Well, we have our formulary, we have PDEX, and we have Kallem Blue Button, and all of those go out to consumer apps via the Smart on FHIR OAuth supported security layer. So they're all secure APIs. The provider directory sits outside that. It is open to the world and can be queried by anybody. So this is where we are looking at providing the patient access API, but for the new prior authorization rule, we've also got to provide basically the same data set with some minor changes, but through different mechanisms, i.e. using bulk API, so for different audiences, one of which is the provider community, the payers in-network providers, and the other being other payers. So when a member chooses to switch from one plan to another, they're able to take their data with them, and they'll be able to go to their new plan and say, go get my data, and provide their old account credentials, their old, basically the information off their coverage card, to the plan, so that they can perform a member match with the old plan and retrieve the data incorporated into the patient access API. And of course, that means into the data set that can be released to providers and payers. So basically helping the longitudinal record start to permeate across the industry as you move from plan to plan and provider to provider. Let's go on to the next slide. So Provider Access API, as I say, will be a combination of payer data exchange, the clinical data, which will include prior authorization information. And that will include the status of the prior auth, and will also indicate, will save prior auths that were declined or denied by a payer, so that there is a history, and that those denied prior auths will be available for 12 months in the API. And obviously the consumption of a prior authorization will also be reflected in those prior authorization profiles that can be made available to patients, consumer apps, but also to providers, and obviously through the peer-to-payer API as they move from plan to plan. So we have to take the claims information. I think there will be a question that we will put to CMS around formulary. It is not clear whether the formulary needs to be exchanged with providers and with other payers under the terms of the rule. Again, it would make potentially more sense for formulary to be published as an open API, so that it could be queried appropriately, rather than making it part of these bulk transactions. So interesting things we will have to get CMS guidance upon there. There may also be challenges in how payers have implemented patient access API today as to the reality of, can we merge the claims data within a non-financial view and the clinical data and those prior auths all into a single, effectively, data set that is made available to providers when they come knocking on the door, wanting to see the history for the patients, the members they're treating. Let's go to the next slide. So let's talk about PlanNet. PlanNet is basically the name for the payers provider directory. The main thing that's going on here is there is a lot of coordination going on with the FAST accelerator to make sure that the developments that are going on in the FAST national directory stay in sync with the implementation in the provider, in the PlanNet world. And again, this is a case where there are literally hundreds of provider directory implementations out there, because payers needed to implement that as part of the interoperability rule. And so there is obviously interest in making sure that the provider directory of PlanNet is actually consistent with the national directory, because you'll be basically exchanging the same data. And so one of the things that is being looked at in an update to provider directory, it has been pretty stable since its original issue. But one thing we are looking at, again, like formulary, is actually incorporating a bulk API request. And you may think, do you really want to do that? But it may make sense for payers to have an instance ready for a bulk exchange of data, rather than having consumer apps and other sources coming and basically hammering all of the different API endpoints within the PlanNet API to basically build that provider directory. So we're looking at actually incorporating a bulk extract option as part of the next update. So if you're interested in that, you should definitely follow the workings on in the both FAST National Directory and our PlanNet review sessions that we have with PDEX. Let's go on to the next slide. Let me bring it all together. So what's really going on? PDEX STU2 is currently waiting to go to publication. If you had put in tickets to JIRA in the ballot back in May 2022, we really need some of those negative votes to be withdrawn so that we can actually clear the hurdle and actually publish. And then, having published, which we hope to do in the next couple of weeks, we then want to open up PDEX to an update, so let's call it STU 2.1, where we can incorporate the provider access APIs at bulk exchange and the payer-to-payer API. And obviously we're looking for testers at the Connectathon in January, and we will also be doing the same in May and September. You can pretty well bank on that. We will be covering both PDEX and formulary. So formulary, we are looking to do this bulk formulary download. It is already as a draft in the current IG, and the work afoot in formulary at the moment is really harmonization with the terminology capabilities at HL7. And again, on PlanNet, it's really about that bulk download option will be added and staying in harmonization with the FAST National Directory. So that's really everything that's going on in Payer Data Exchange. There is a lot to be done. We are definitely looking for input. How can you give us that input? Basically, come to our meetings. They happen every Friday at 1 p.m. Eastern time. So if you go to the event calendar at HL7, you can find our meeting. Please come join us. We really are looking for input. We are drilling down into all the nuances of provider access and payer-to-payer right now, so you can have a real impact on actually how those APIs work. We're really looking for that input. So with that, obviously there is links to prior auth. So what better for me to do than to hand over to Michael Gould, who's going to talk about all the great work that's been going on in burden reduction. Over to you, Michael.
Thank you. Thank you very much, Mark. In this section, I'll review how the collaboration in our community has helped mature the burden reduction and clinical data exchange FHIR implementation guides. Starting with the first of these three guides for burden reduction, coverage requirements discovery allows the provider to determine if there's a documentation or prior authorization requirement for the item or service that they want to order or schedule, or for an encounter that's beginning with the patient. Second is the documentation templates and payer rules guide. This facilitates the capture of information from the EHR to meet payer documentation requirements using FHIR questionnaire resources to express them, and clinical quality language as the standard to express the rules that automatically populate the questionnaire from the patient record. Third is the prior authorization support guide, which standardizes the exchange of prior authorization requests and the associated documentation between the provider and the payer, including the conversion into and out of the 278 standard to meet HIPAA transaction requirements. Some organizations have implemented the entire burden reduction workflow. That is the apps and the APIs from these implementation guides, CRD, DTR, and PAS. So let's go to the next slide. So first, the coverage requirements discovery implementation guide supports the ability for providers at specific points in their clinical workflow to request information from the responsible payer regarding coverage and documentation requirements for planned treatments, referrals, and diagnostics. CRD has continued to mature and the newest version was published on October 20th of this year. New updates to this guide include improvements for clarity and to improve the functionality of the guide, explicit expectations with respect to performance and accuracy of CRD services, use of system actions to automatically execute responses, and also allow response to include questionnaire response and determination. A consistent theme through all of our implementation guides is our call to action. Contribute by having your in-kind resources participate or continue to participate in weekly public calls, participate with partners in testing and connectathons, and essential to the quality of our work, adopt and implement these guides. Part of the maturity of these implementation guides, as well as specifically for CRD, is that they're going through new versions, and there are changes, and there's a change history that you can find in the implementation guide that will help you deal with how these guides mature. As well, in that call to action for participation, there's the opportunity to find partners to test with, and also to work with people and collaborate with people in the community to learn more as you become more familiar with these workflows and the implementation from these guides. So let's go to the next slide. And this slide depicts the exchanges within and between the provider and payer to support CRD. So the purpose is to take the guesswork out of patient-specific coverage by sharing authorization or process requirements right in the provider workflow. Also to expose information about patient benefits when the care team is most likely with or near the patient, so options can be discussed and decided upon with that patient. CRD can be triggered by scheduling an appointment, can be triggered during the order process, can be triggered on demand, or at the end of an encounter. The API exchange responds with whether a prior authorization is needed and points to documentation requirements with the ability to link to the DTR app. CRD may return an authorization if there's sufficient information and the payer supports the delivery of an early determination. So let's go to the next slide, please. So shifting gears here to the second part of the burden reduction stack, I'll focus on documentation templates and rules, or documentation templates and payer rules. DTR builds on the CRD guide to specify how payer-specific rules for required documentation can be executed in a provider context. Remember, these are payer rules that today often are posted on public websites as PDF documents. So we're looking to make them computable in the EHR environment in a way that doesn't disrupt the provider workflow. Provider burden would be reduced by reducing manual data entry to supply the relevant documentation to meet the criteria of the policies. The DTR guide facilitates the capture of information from the EHR using FHIR questionnaire resources as the basis and using clinical quality language as the rule standard to automatically populate the questionnaire from the patient's record. Electronic questionnaires from payers utilize CQL to automatically extract the relevant data from the patient's record to pre-populate that required information. It also allows for practitioner review of that information. So some new updates to the guide include support for improved functionality, where parts of the guide have been rewritten for clarity. There's also a link to structured data capture implementation guide for adaptive questionnaires These allow questions that build on prior responses to prior questions in the questionnaire. Multiple launch modes for DTR, of course from CRD, but also as a standalone launch, a standalone launch of DTR, or to launch it from PAS or CDEX, which we'll see in a couple of minutes more on that. Some of the other improvements are the use of the questionnaire response from CRD, the ability to return a service decision, and the ability to hand the documentation bundle from that questionnaire and the extraction of the clinical data to support the request. Get that documentation bundle to PAS and post-acute orders as well. Once again here, as I mentioned with CRD, the same is true here for DTR. Our call to action is to ask you to contribute by having your in-kind resources continue to participate or start to participate in weekly public calls. Participate with partners in testing and connectathons, and most of all, adopt and implement these guides. Next slide, please. DTR uses the context of CRD or CDEX associated claims or prior auth requests for provider, patient, and orders. That's the context. And retrieves templates and rules from the payer without the need to re-enter information. So it retrieves information from the patient's medical record and pre-populates it into a template. This eliminates duplicate manual entry. It prompts for missing information and allows for the practitioner review, again, specific to the service that's being requested. Complex guidelines can be handled with the adaptive forms that solicit from the patient's record or provider the relevant information based on prior answers. This significantly reduces the need for large amounts of clinical information to be supplied with a prior auth in a shotgun approach. This process replaces the need to request, gather, and submit documentation, tending toward minimum necessary and reducing the need to filter through the full patient record to find relevant information. Let's go to the next slide. So moving to the third part of the burden reduction guides, here I'll focus on prior authorization support. Prior authorization support, or PAS, defines FHIR-based exchanges to enable the provider at the point of service to request an authorization, including all the necessary clinical information to support the request, and then receive an immediate decision on the authorization from the payer. The Da Vinci sponsored exception to the 278 requirement in HIPAA that was granted by CMS to the Da Vinci project, that is to use PAS using FHIR only. This is in production. Some updates to the guide include support for subscriptions that now replace polling as the way for payers and providers to complete the interaction in PAS. Standard error responses have been included. DTR can be used to ask for additional documentation in a way that's been built in. And other updates have been made to the guide to reduce the inconsistency between PAS and the X12-278. And just in case you missed it earlier, again, I'd like to make that call to action. Participate in the weekly public calls. There used to be 3 public weekly calls for this. This has now been combined into one call on Wednesday at 11 a.m. Eastern Time. In addition, test these guides. The burden reduction stack has been one of those connectathon tracks where the partners coming together to test have done the pre-work that's necessary leading up to the Connectathon event, so they can demonstrate how the guide works in action in the diversity of implementations from the guides. So again, underscoring the participation in testing as well, and don't want to leave it out, the adoption and implementation of these guides. If you're new to the Da Vinci community, you can draw upon the knowledgeable members and others in the community to help you both understand the guides, implement them, and test them. So let's go to the next slide. Prior authorization supports the ability to use a FHIR bundle to exchange prior authorization information between the prior provider and payer, using a service that converts the FHIR bundle into and out of the 278 transaction. This is by design in the implementation guide. Note that the payer, note that the bullets under the payer arrow are in sequence from left to right here, where the bullets under the provider arrow in the return flow are in sequence from right to left. So the flow from provider to payer, and then back from the payer to the provider at the bottom. Let's go to the next slide. Thank you. In terms of new capabilities for PAS, with the change to use R5 FHIR subscriptions in place of the polling model that was previously in place in PAS, when a prior authorization is pended, in other words, that determination is not an affirmative or a denial, the payer may be seeking additional information. So with subscriptions, the system is notified by virtue of that subscription, rather than repeated checking for responses to requests for information. So the PAS guide now requires subscriptions to be supported, includes for support for CDEX to satisfy the request for that additional information that's notified via the subscriptions, and it has the ability to specify FHIR questionnaires that are administered by DTR as well. Let's move to the next slide. Taking an overall look at all three of these guides for burden reduction, some of the key benefits from implementing CRD, DTR, and PAS, which is also aligned with the prior authorization requirements, documentation, and decision, or PAR-DD requirement in CMS's proposed rule for advancing interoperability and improving prior authorizations. As Mark mentioned, the CMS 0057 rule. Standardized interactions from across all providers and payers is a benefit of these implementation guides. The ability to provide real-time access to payer requirements for prior authorizations and the documentation that supports them. Support for clinical workflow activities to trigger interactions with payers, enabling consideration of coverage and financial responsibility as part of clinical care. Enabling work to be performed by the appropriate person, or in some cases, automated. Saving relevant prior authorization request and response information in the provider's EHR. Minimizing the collection of documentation to that which is necessary for the specific service. Avoiding the duplicate manual entry of information, for example, into other systems, such as a portal that's not necessarily connected to the provider's EMR. Automated the collection of documentation to support the need for a service that requires prior authorization. And this adapts easily to new and changed information requirements or policies as well. Let's go to the next slide. Continuing the theme on benefits, this really looks at how the actors in this benefit. So the adoption of CRD, DTR, and PAS provides specific benefits for patients by giving the patient and the provider the ability to see and discuss alternatives for care that may include out-of-pocket cost considerations. It allows for more rapid treatment approval and to avoid unnecessary delays and that complicate care delivery. And knowing that a prior authorization and what its status is also now possible in the not too distant future by sharing information from this improved flow to the patient's app. As Mark mentioned earlier in the section on PDEX, requirements are out there for prior authorization information, decisions, and status to be part of the patient app. Providers will benefit by having real-time access to payer policy requirements, moving forward from static PDF policy documents. They'll benefit by automating the collection of supporting documentation in place of manual entry or re-entry, and standardized workflow across multiple payers with each provider. Payers will also benefit by workflow tailored to the specific service and members' individual needs and benefits, the ability to engage with providers earlier, and improve relationships with members and providers. So let's go to the next slide. Clinical data exchange is separate from the burden reduction guides, so moving outside of the burden reduction stack, but showing how distinct guides support each other. You'll see that clinical data exchange supports burden reduction as well. So the clinical data exchange FHIR implementation guide focuses on data exchange from the clinical context to support claims, prior authorizations, referrals, quality, and risk adjustments, and therefore links to several other IGs. Recent updates include the addition of the $ submit attachment operation and requesting attachments using a FHIR task resource. Looking ahead to further specify the use of CDEX in PAS and DTR to address needs for additional information. And once again, and CDEX is a great example of our call to action, contribute by having your in-kind resources participate or continue to participate in the weekly call. I believe the CDEX call is on Wednesdays at 3. And testing in the connectathons, CDEX has been another exemplar in testing at the connectathons. And also remember to begin to adopt or implement these guides. Again, I've been reiterating this throughout the presentation, but that is the value and the success of the Da Vinci community in implementing. So let's go to the next slide. CDEX is a highly useful means for providers to send attachments for claims and prior authorizations when payers request additional information or solicit an attachment, as well as when providers submit additional information, either in response to a payer request as that solicited attachment or submission of an unsolicited attachment. Additional information may be more meaningful in a document-oriented structure than as discrete data. For example, history and physical narratives or study reports from pathology or radiology. Sending these as attachments may relieve the potential burden of decomposing or recomposing the information and thereby maintaining context. Let's go to the next slide. Clinical data exchange requests and responses from payers to providers and back can be accomplished in 2 ways. Note the orientation on this slide starts at the left with the payer, and in the direct query approach, the payer would be initiating a request that the provider responds using CDEX. Where needed, for example, when input is needed for a specific practitioner, a FHIR task resource would engage the practitioner with a request for them to respond within their provider system or EHR. Let's go to the next slide. Here, uses of CDEX described have found a strong majority, even without opposition, to expanding the effort on CDEX user scenarios, coupled with implementation advancements and testing in greater detail. Let's go to the next slide. With strong support for expanding CDEX, even broader participation benefits the implementer community. So please join the community calls on Wednesdays from 2 to 3 p.m. Eastern and Connectathon testing efforts. Apologies, I did provide some confusing on the timing of the CDEX calls. The correct timing is Wednesdays from 2 to 3 p.m. Eastern. Let's go to the next slide. So to wrap it up here and summarize both burden reduction and CDEX, the connection of burden reduction and CDEX strengthens the interoperability stack to account for scenarios that can be concluded with automation and when expert interaction is beneficial. CRD has increased the opportunity for a head start on the discovery of requirements with new hooks in a move from informative cards to system actions, and to add efficiency to the flow when a prior auth is required, or prevent waste when an authorization is not required. The DTR guide has been improved with adaptive questionnaires, bundle transfer to PAS, and several other improvements that just wouldn't fit on a slide. PAS also has many improvements, among them subscriptions and CDEX integration. And CDEX has added solicited and unsolicited attachments in the FHIR task resource, which I just reviewed, as well as connection to burden reduction. Thank you for the opportunity to share these advances with you today, and I'll now hand it over to Jocelyn.
Hey, Mike, that was great. And if I can get other folks to join us back on screen, we've got a couple questions to clear. I'm going to tell you, I live and breathe this stuff on a daily basis, and whoa, that was a ton of content you guys just put out, and it's really impressive, just the volume of work and the detailed level at which you guys shared that today. I think that this will be a good session for folks that are onboarding. I'd maybe like to start a little bit sort of wider. When I think about getting to work with you guys as early implementers, many of you, and as leads, triaging and onboarding new people to Da Vinci and in a large part often to the FHIR community in general. I guess maybe just quick round answers, not detailed. Maybe if we can get one round from each of you guys of sort of like, what do you think the best way is it for somebody that's new or is early in their journey to get engaged, and sort of what's the benefit of coming to one of the use case calls versus just picking up the guide and using it in your office with your colleagues directly? And I'm going to have you guys go as you are on screen with me. I'm going to go Mike, Mark, Crystal, and Teresa.
Well, I've actually got to know a few new people that have come into this world. So definitely joining the weekly calls does provide a lot of context. Certainly, if you're an individual study, picking up the guide and reading it is important. Keep in mind that there are multiple versions of guides, and it's important to take the most recent one as one that's evolving, and the most recently published version as the more authoritative guide when it comes to implementation.
What I would say, Jocelyn, is just get involved. I mean, we have a lot of these calls. We have a specific session for implementer questions. So if you picked up the guide, you're trying to work out, I'm trying to implement this, and then you get something that is specific to your environment. You can come and ask that question. It could end up with a ticket that actually ends up improving the guide. So just getting involved, really, you can come along, you can look, and you can just listen, and then build up the bravery and just ask a question. You'll find it's a very helpful community, And the same goes when you get to the Connectathon. There's a ton of resource we've got now for getting ready to get to a Connectathon, and then just come along. And it's actually when you start trying to work with others that you find issues. We had the same thing in PDEX at the last Connectathon, where reading the guide and trying to interpret what it meant, and we ended up actually going and grabbing somebody saying, what did you originally mean when you put this in your guide? And it really helps to resolve these questions. And the best way, it's a great community, get involved.
Yeah, just adding what Mark said, it really does help to come hear what others are struggling with when they ask questions and bring those perspectives to the group. And then you've got the experts on the call who wrote the guides there really to provide that support and guidance for implementers. And also join the calls to stay abreast of what's going on. Hear when the latest version of the IGs have been published, or when they're going to be published, or what roadblocks we've run into, or what successes we've had. It's just a great opportunity to stay abreast and know what's happening with each of the use cases.
Teresa, you're on some of the newer guides. Yeah, I'd love to hear your perspective.
Yes, yes. So I think that one of the greatest benefits of just coming and even just listening to the weekly calls is the fact that you're going to learn a whole new language, and it's not any different than the language that you're using. It's just different words. So I don't know how many times we've approached to say, oh, this data element is named this. And somebody says, well, what does that mean? And then we start to explain, they go, oh, in my organization, it's a blah, blah, blah. And that happens so many times. And, if you're not coming to the calls, when you pick up those guides and read them, you think this isn't for me, but it really is. So it's an opportunity to come and it's not even just get your voice heard, but to understand what's going on and then to contribute to the vocabulary building, because we may have just a few people there putting in their input, but in the greater ecosystem, maybe they're using different words, maybe it's different concepts, maybe the workflows are different in a regional payer than it is in a national payer. And what does that look like? And you need to have your voice heard too. So what I've noticed is that it's really been one of these like, oh yeah, that makes sense. And light bulbs left and right, and people go, oh, I can take this back and explain this to somebody now, which is half the battle, is getting the business and the IT to talk.
What I build on what Teresa just said is that don't be afraid that you can think that these guides are very technical, they're IT heavy, but we are desperate for input from business experts that understand how the business works, because these guides only work when they meet the business need.
I think that's a great point. And I think that this is something that we grapple with, I think, as we recruit folks to come in and onboard them into FHIR and into the HL7 world that maybe haven't been using FHIR or haven't been living and breathing around clinical data. And I think that the thing we hear when we survey members about the benefit is, I think you guys all touched on it, is that ability to be in a room with your peers, both your technical and your business peers, and figure out what else people are struggling with and how should we be solving these problems, because so much of what we're doing really is first of doing this in a real-time interaction versus sort of large transaction sets or sort of old school, more EDI-based transactions or documents in, information stuck inside a document. So I think that's great. I'm going to be mindful that we're at 5:31. You guys are amazing. Thank you so much for all the work to get it here and to put this content out. And a reminder to folks that we will actually take the recording and a transcript and post that out to the HL7 Confluence site under Da Vinci. It's found under our calendar. And I think given how well tonight went from a technical perspective, I'm going to try and push to maybe see if we can dice it up into some sections too, so people don't have to sit through all hour and a half and can just dive in on the section they're most interested at a given point in time. But thank you, Mike. Thank you, Mark. Thank you, Crystal. Thank you, Teresa. And thank you, Leslie, for the steady stream of links and resources for folks throughout the hour and a half. And I'd be remiss if I didn't thank Alex Goss, who is the one who puts Community Roundtable on for us every single month. It's been super fun to sub for her this month, and we will see you guys in November. Thank you all.
Thanks a lot.
Thanks,
guys.
Thank you.
Great job.